Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is January 22nd, 2026. Big winter storm coming. Still don't know how much snow, how much ice we'll get, but we're hunkered down, we're ready. And so today, great segue. Today we're going to talk about this latest publication in this week's issue of the New England Journal of Medicine of Sacituzumab or Sacituzumab govitecan plus pembro in metastatic triple-negative breast cancer that is strongly PD-L1 positive, which is not in the title. This is a CENT4/Keynote D19. So the Sacituzumab govitecan, they gotta call it a CENT4. The pembro folks, they gotta call it a Keynote. So it should be like ASNode or KeyCent, or KeyCent sounds better. I think we'd agree. But we have to have two names for this, which is it's annoying. Okay, so this is metastatic triple-negative breast cancer or locally advanced triple-negative breast cancer that is PD-L1 composite proportion score, so not just tumor, but all the cells in the sample. Composite proportion score greater than 10%, and this is based off of Keynote. I think it's 355, which was an older study that looked at pembrolizumab plus chemo versus chemo alone, and found that the OS benefit was restricted to those who had this PD-L1 CPS greater than 10%. And the chemo choices are nab-paclitaxel, Taxol, conventional or solvent-bound paclitaxel, or then carbogem, and that's what this study is pembro plus those chemotherapy options versus sacituzumab govitecan plus pembrolizumab, same standard doses of the antibody-drug conjugate and pembrolizumab. Sacituzumab govitecan does have PFS and OS benefit in the metastatic breast cancer setting already. That's after at least one line of therapy for triple-negative breast cancer in the metastatic setting, and then other systemic therapy. So reasonable to try to look at it moving forward. This is a phase 3 study done in 28 countries. Again, they're all PD-L1 CPS greater than 10%, and then triple negative, so ER/PR positive. They're giving the standard doses for just completeness. The paclitaxel dosing is 90 per meter squared, days 1, 8, 15. Skip a week every 28 days. Nanoparticle albumin paclitaxel is 100 per meter squared, days 1, 8, 15. Skip a week every 28 days. Gem, 1,000 per meter squared, milligrams per meter squared on days 1 and 8. Carbo AUC2 on days 1 and 8. I do want to point out this carbogem arm. A low-dose carboplatin, there's going to be better tolerated than the higher-dose carboplatin. If you go back and look at Keynote 355 and you look at the subgroup analysis, you see the median overall survival of pembro plus chemo was about 30 months in the Abraxane arm, about 29 months in the Taxol arm, and then only 19 months in the carbogem arm. Now, those folks getting carbogem may be getting that because they have a poor performance status. They're going to do poor anyway. Don't know, but there might be some heterogeneity here in the results based on the chemo that these folks are getting. Pembro was capped at 2 years, so 35 cycles total. You got 220 people in each arm. Most of these folks were under the age of 65, only 26 over the age of 65. Median age was 54. So some younger folks that we kind of not unexpected to see this in a triple-negative breast cancer patient population. You're going to have more younger patients. This was all hormone positive. You'd expect an older age group. This was an international study, so but a good portion of these folks, about 40%, were in Canada, U.S., or Western Europe. A third were de novo metastatic disease, so had never been diagnosed with triple-negative breast cancer before. This is their first diagnosis. About half had their disease recur more than a year after completion of curative intent therapy, and 18% had recurrence 6 to 12 months after recurrent treatment. 50% got a taxane, and 49% got carbogem in the chemo plus pembro arm. If you go and look at the supplement, only half the people in this study had previously received a taxane. Half had previously received an anthracycline. 15% had received platinum. About 20% had received capecitabine. which is a little odd because you would think those numbers would be about 67%. Because only a third were de novo metastatic disease. You would expect more of these patients to have received, anthracycline or taxane. And so that's maybe something to keep in mind here, making sure that this chemo-only arm, or chemo plus pembro, that they're getting the best that they can get here. Our primary endpoint is progression-free survival. Triple-negative breast cancer, it's not a good diagnosis. So it seems like we could have done OS as our primary endpoint here. If that's significant, then they're going to formally test OS later on at an alpha level of 4.99%. So we get to our results here. We do see a statistically significant improvement in overall survival. That hazard ratio is 0.65, 95% CI, 0.51 to 0.84. Median PFS, if you're interested in those measures of central tendency, are 7.8 in the chemo plus pembro to 11.2 in the investigation arm with sacituzumab, govitecan, and pembrolizumab. I will point out that these Kaplan-Meier curves separate more at 12 months than they do at 6 months, and even more later on. Now, the median duration of follow-up here, I think, was 14 months, so looking beyond that, 12 months isn't probably a sound advice, but we are seeing some suggestion, that there certainly is a treatment effect here. We see a little bit more response rate in the experimental arm versus the chemo arm. Looking at the subgroup analysis, there's some odd stuff here. There's some discrepancies here. And the first thing, maybe, I guess I don't worry about it, but the folks who are de novo metastatic, 75 in each arm, so small numbers, caveats aside, hypothesis generating, yada, yada, yada. Point estimate is 0.89, 95% confidence interval is 0.59 to 1.34. Median PFS 7.7 with chemo plus pembro versus 8.1 with sacituzumab, govitecan plus pembro. Those are about 8 months. Those are basically the same. Doesn't seem to be an improvement of doing sacituzumab, govitecan versus chemo pembro if you're de novo metastatic. Okay, doesn't look that way, right? Now that's a caution statement with not a high level of confidence. Contrast that point estimate of 0.89 for de novo metastatic disease with 0.52 if the disease recurs more than 12 months later. And again, those folks who have disease recurrence after curative treatment, they probably got the anthracycline, they probably got taxane. So putting them on an arm where either they're going to get taxane or carbogem, which maybe is not a great regimen, looks to make a little bit of sense. We do see, the median PFS for those folks who are getting carbogem plus pembro was 7.4. It was 9.2 in chemo plus pembro. So there's this trend here that maybe carbogem is not as an effective agent in these triple-negative breast cancer patients. And if you already got a taxane, yeah, okay, maybe not. We do see, similar benefit there, although the hazard ratio is a little bit lower because the folks getting taxane did better than the folks getting carbogem. So we don't have all of these things tied together. It would be interesting to look more at those folks who are de novo metastatic disease. Was there anything we can tease out to help guide, if we're doing a chemo backbone, is one of those drastically better or drastically inferior to sacituzumab, govitecan plus pembro? OS benefit is immature at this time. That's what we really care about. Now, before we talk about OS benefit, I should give the caveat that 80% of folks who progress on chemo plus pembro went on to get the sacituzumab, govitecan as monotherapy after progression, either per protocol as a crossover or because it's FDA approved in that setting in many countries or by the regulatory body in Europe or wherever it would be. So it's going to make it look like there's probably not going to be an OS benefit. And if you look at the Kaplan-Meier curve in the estimate, there doesn't seem to be any OS benefit. If you look at it at a glimpse, it'll look like the Kaplan-Meier curves perfectly overlap. Again, early median follow-up, 6 months, you're not seeing any difference. Then there's a lot of censoring after 6 months. I will add this caveat, though. If you look closer than just a glimpse, it looks like the chemo pembro is doing a little bit better early on, and then the curves kind of cross, and that's something to continue to follow over time. And it seems to be the question we have in triple-negative breast cancer is sacituzumab govitecan an active drug and a good drug to use? Seems the answer is yes. The question is, should it be used first line plus pembro in the metastatic setting in these folks who are PD-L1 super positive CPS greater than 10? Or is it safe to add it in the second line later on? Are we gaining any OS benefit by moving it up front? That's really the question here, and that remains to be seen based on this publication in the highly reputable New England Journal of Medicine. It is reassuring to see we're not seeing crazy toxicity data with this combination, giving two expensive drugs, two monoclonal antibodies. One curious thing here is that immune-mediated adverse events were less with sacituzumab govitecan, 30% versus 40%. The protocol said that you could give Dex as an antiemetic. You should give 3 drugs as antiemetics if they have problems with just 2. We did see more nausea and vomiting with sacituzumab govitecan compared to the chemotherapy arm. So did the steroids blunt some of the immune-mediated adverse effects? If so, we're still seeing benefit. Does that mean anything? GCSF prophylaxis was used in 63% of these folks compared to 41% in chemo, and then antidiarrheal prophylaxis was given to over half in the sacituzumab govitecan group. So not, even though there might be some folks hyping this as a chemotherapy-free treatment, there's more diarrhea, there's more nausea, there's a similar amount of neutropenia. There's more alopecia, 52% versus 32%, more with the sacituzumab govitecan. There's more vomiting, twice as much vomiting. This is not, an easy regimen, and I think it'd be incorrect to call it chemotherapy 3. We forget the govitecan is SN38. That's the active metabolite of irinotecan, and we do see those irinotecan-based toxicities. So, a drug that is, this regimen is in the guidelines as not a category 1, but as a category 2A. So it is an option. Certainly if you have folks, in my opinion, who have already had taxane and you don't think carbogem is effective, it makes a reasonable option to use in those folks up front. Would imagine this to go through the regulatory process and be FDA approved at some point, just because we do have this PFS benefit. I don't think we're going to see OS benefit. The primary endpoint was PFS. So that's where we leave it with ASCENT-04 and Keynote D19. Did not talk previously about ASCO GI, which happened a couple weeks ago, 1st of January this year. Maybe the most notable one, or the one that I heard the most about, was talked the most about on social media, was Horizon GEA-01, so gastroesophageal adenocarcinoma. So this is zanidatamab, which is a bispecific for HER2, blocks 2 different points, 2 different epitopes on HER2, so double HER2 blockade, you can almost think of it, plus chemo, plus or minus tislelizumab, which is an immune checkpoint inhibitor in HER2-positive, HER2-amplified, locally advanced metastatic GEJ, or gastroesophageal adenocarcinoma. And there are 3 arms, right? So there's zanidatamab chemo, there's zanidatamab chemo plus the checkpoint inhibitor, and there's zanidatamab plus chemo, or chemo plus trastuzumab. There is not a control arm that is what we would consider to be the standard of care in this space, which would be trastuzumab plus pembro plus chemotherapy based on Keynote 811, which, we had the interim results in 2023, publication, I think, in 24. Patients started on this study in December of 21. So there was a lot of hype, and there always is sometimes a lot of hype when there's a meeting about this, as people were pretty careful to say a standard first-line regimen, not the standard first-line regimen. It was, you look at the slides of the presentation, and they're doing the cross-trial comparison, seemingly to hype up that the OS benefit with the zanidatamab arms was numerically higher than the pembro arms, which you can't do. And if you're going to do that, change your study, change your protocol in the middle to give people randomized to trastuzumab and chemo the ability to get pembrolizumab, which is what we would do. It's below the standard of care, which is a problem continually in oncology studies. So, unfortunately, the other design flaw here is they're doing comparisons of zanidatamab plus chemo versus trastuzumab plus chemo, and then tislelizumab and chemo compared to trastuzumab plus chemo. They're not comparing zanidatamab chemo to zanidatamab tislelizumab plus chemo. Numerically, doesn't look like maybe there's an addition to adding this. Supposedly, PD-L1 status does not predict efficacy with tislelizumab. Would like to see the publication of this. Zanidatamab is previously approved for HER2-amplified biliary tract cancer, which is a disease state we struggle to treat. That is, that's the foothold they have in the market, but they're looking to expand with this. approval here. There was also the Lustro, I think it was a Lustro 02, which is a phase 2 study. Can't take a whole lot from a phase 2 study, but it was looking at, I believe it was nivolumab plus chemo plus Folfox and the Claudin 18.2 inhibitor zolbetuximab, which is a good question to ask is how much do we value the Claudin 18.2 positivity and PD-L1 positivity in adenodes of the stomach and of the esophagus. Again, a question that needs to be answered. So we're seeing people at least starting to ask the questions, can we give these drugs safely together? It looks like the answer is yes. Don't know about the relative efficacy with the phase 2 study. And then lastly, I want to talk about the Pitt on HBO Max, since it's a medical drama. Have yet to see a pharmacist in the show. The opening scenes include a patient in the hospital, and the attending says, "What are your medications?" And like the patient's wife or daughter has a bag, and like the doctor just rolls his eyes. A pharmacist is going in and doing that med rec. There was a very notable example of priapism in this study, and as someone who teaches erectile dysfunction, I'm really questioning, should I show this in class? Probably not going to. And then one of the big subplots right now, which some of you may have seen in your positions and jobs, is someone new comes in a position of authority and wants to change things up, and how that process may go and ways to implement that change. Well, you might, if you have done or read or know anything about implementation science, I think there are a lot of examples of how that may be done well and not done well, and communicated well and communicated poorly. Seems to be that's going to be a plot going through this. And then AI, a lot of talk about AI so far early on. So if you haven't, check it out. Interesting. We'll check in with that from time to time, just as something interesting to talk about, because hey, I want to. All right, that's what I have for you this week. Thank you so much for listening. You can follow me on social media at PharmDeetNib on X and OncoPharmPod on other social media platforms. And if you didn't check out last week's episode, listen to it. That's also available on YouTube with slides as well. So thank you, and until I talk to you again, remember, doses matter.